talking about a muscle or muscle tendon injury. Okay, so a sprain is something that happens to a ligament and affects the joint, the capsule of the joint. Whereas a strain is something that's going to happen to the muscle tendon unit, anywhere along the length of the muscle tendon junction. We call that, we consider that a strain. So this is where you guys probably used to say, I pulled my muscle. So that means you strain your muscle. You should have anywhere from a little bit of a pull to a complete tear. So again, that first, second, and third degree classification that we're looking for. So etiology is how it happens, right? So what happens with strain? It's an accessible, forcible contraction. So lifting something that's really just so heavy, and you're trying to producing so much force to the muscle itself. That one's not as common. We don't see that as often, but it can happen. The excessive forcible overstretch is obviously the one that we're most familiar with, right? That's when you do the splits or something like that. Also, your hamstring goes, or your groin goes, or that's the one that we're kind of a little bit more familiar with, that stretching motion. But then we also can have chronic overuse, which isn't really macro trauma. That would be getting more into micro. But if you have something that's so chronically overused that it gets so inflamed and irritated, it gets weaker and weaker and weaker, and then eventually it's going to rupture and go into a complete tear. So that's why that has to be in this sort of category. So when we think about the muscle tendon junctions, okay, and the muscle fibers themselves, so we have to understand a little bit about the physiology of the muscle. So you have to go back and rethink that. Well, what is the muscle? What does it look like? Remember, we got the myofibrils that'll bundle together into the fibrils, and then they get bundled together into your bigger muscles. Like sliding filament theory, good old sarcomeres and cross bridges, cycling, tracking, all that kind of fun stuff. And then as we go away from the muscle belly, where the bulk of the muscle is, we move towards where they hook onto the muscle or to the bone, and they hook onto the bone via their tendon. So what we have in the middle of the muscle and the muscle belly is not the same as what we have at the insertion or the origin of the muscle. The tendon is a completely different sort of makeup and construction. More collagen in it, not as stretchy, can contract, but not as easily as the muscle fibers themselves can contract. Let's see. So when we think about common muscle strains or pulls, what muscles do you usually sort of envision having that injury happen to them? The groin. The groin? Quads or hamstrings. Okay, any other ones that you think of? Calf. Okay, anything else that you think is having a muscle strain or muscle pull? Lower back. Okay. So other than the fact that those all tend to be, we're talking about all lower extremity problems, what do all those sort of muscles have in common? What's one common thing that the quad, the hamstring, the groin, the low back muscles have?
They're long.
They're long, and because they're long, what do? They stretch. Think of your back muscles. Okay, think of your hamstring. Where does your hamstring start? Where does it finish? Starts on your butt, yeah?
They're double jointed?
Double jointed. Okay, so they cross more than one joint. Whenever a muscle crosses over a joint, it has to have function on that joint. So because these muscles cross two joints or more than two joints, they have to be working constantly whenever those joints are working. So the hamstring is working all the time. It's a weak hip extensor and it's a knee flexor. So whenever you have that hip inflection and you're extending the knee, you're really putting a lot of stretch on that hamstring. So when people blow their hamstrings when they're sprinting, they blow it just before they get their heel on the ground. Not when they're standing on the ground or pulling through. It's as they're getting just about to put that heel on the ground where there's maximum eccentric load happening and that muscle is being asked to then contract really quickly to keep them running. Okay? Low back muscles. Okay, we got multiple joints, right? Each vertebrae, each vertebral level has joints. So those muscles cross several segments in the low back. Okay? That's one of the reasons why the long head of the biceps and the shoulder is more frequently involved, because it crosses the shoulder and the elbow. But you don't hear people say, I've strained my biceps as frequently as you do the lower extremity muscles, okay? And in the calf muscles, it's only one of the two. It's not the soleus that's usually damaged, it's the gastroc, because the gastroc crosses the knee and the ankle, okay? Okay, so here's the chronic overuse. So tendinitis, tendinosis, tendinopathy. As we go through the course, you're going to hear me use the term tendinopathy a little bit more frequently than tendinitis. Research has been coming out for the last 10 years or so where they've split tendinitis almost into two groups, where you have a tendinosis and a tendinitis, and the big name for that is a tendinopathy, which just means pathology of the tendon now. And I'll talk about that in a few minutes, I think, what the differences are. So when we have that repetitive inflammation in that tendon, the tendon starts to eventually break down and weaken, and therefore it's more susceptible to tearing and rupturing. Okay. So first degree. A lot of you guys have probably had first degree muscle strains just working out. First time you go to the gym and you work out and you're like, I can lift that. And the next day you wake up and you go, oh my God, I'm really sore. So delayed onset muscle soreness technically is kind of a first degree strain to your muscles. Little fibers torn in there, a little bit cranky, a little bit upset with you. You let it heal and recover properly, the muscle actually gets stronger and bigger, hypertrophies. Okay, so that first degree strain is very mild. Slight swelling, little bit of pain that's localized, slight loss of strength, slight loss of flexibility, can't quite move through the range. There's going to be no bruising. Okay, so most of us have probably had muscle strains in the first degree just by going out and working out for the first time. Okay, there's other things that contribute to delayed onset muscle soreness, but that's one theory that's happening. Okay, your second degree strain, again, this is the big gray area, just like it was with the sprain. You've got some fibers that are definitely torn here now, to almost 99% torn. Okay, so these people are going to have a larger area of pain and dysfunction. They're going to have a significant loss of strength. They won't be able to generate the power or the strength through that muscle. And you will not be able to put them on stretch. Okay, it's going to hurt a lot more. They're not going to be able to move through the range of motion. And they're going to have some bruising now because you've torn muscle fibers that have blood flow to them. So the blood is going to leak out into the interstitial spaces and you're going to get some really good bruising happening. Okay, third degree, again, these are the obvious ones. Okay, so these are the ones where you have, they've heard or felt the snap or the pop. Significant loss of strength, probably can't contract at all. You won't be able to move the muscle what it's supposed to do, they won't be able to do it. Or they go way past where the muscle should be stopping that range, they go way past that range of motion. So excessive movement. You will see what we call muscle bunching. So the muscle actually is like a spring and it recoils. So there'll be a hole, and then you see the muscle bunch up. Okay. So these pictures are just kind of give you again, just to show you. You can see the tremendous strain on the hamstrings of the soccer player. And on the adductors of this soccer player, there's your muscle bunching of the torn hamstring. The divot with the muscle bunch. And this person hasn't bruised yet, or maybe it's a really old injury, and he's scarring up now, and the bruising's gone, and he'll still have that divot, unless they surgically go in there and pull that tendon back up and stick it back on your bum bone. Okay, there's some nice bruising coming out of a good hamstring injury right up there. Okay, before we get into this slide, I want to talk about muscle soreness, just in general. So let's put that up there. Okay, so talked already about sort of delayed onset muscle soreness, right? So one of the theories is that it's microtrauma, little wee small tears that's causing a little bit of inflammation and swelling that gives you your pain. Another one that it's lactic acid buildup in the muscle. So there's a couple of different theories, maybe a combination of those that causes that sort of muscle soreness or stiffness. But there's two other muscle sorenesses or pain that we can develop, and those are the muscle cramps that we can get. So just to hand it up, how many people have had a muscle cramp in the middle of the night? A few of you, okay. Good old, it's usually in the calf, and you have to hop out of bed and go, oh,
and stretch that, because it's like killing you. Sometimes it's when it feels like your toes are crossing over on each other. Okay, you're swimming, all of a sudden your toes feel like they're going into knots in there, and you have to like stand on your foot in the bottom of the pool. Okay, that's one type of muscle cramp that we can get. And that's called a tonic muscle cramp because it's a continuous involuntary contraction. So that's like, it's in muscles in tone, so they call that a tonic cramp. And they're not quite sure what really causes that yet. Sometimes they're equating it to sort of hydration and electrolyte imbalances, but they're not 100% convinced. These are the muscle cramps for those of you that had Wednesday's lab. We had that picture of LeBron James coming off he was being carried off the floor, okay? He was in muscle cramps, so he was in tonic cramps. So was it hydration? Was it his electrolytes were out of balance that day? He didn't have enough potassium, or the salts were in his body the right way? Who knows? Okay? But they can be very painful, and a tonic muscle cramp can be so violent that it's that excessive forcible contraction that I talked about a few minutes ago. So you can actually damage the muscle with those cramps, and you can have a first degree, second degree strain from a muscle cramping situation in the tonic cramp. The second type of cramp that we get is called a clonic, C-L-O-N-I-C, clonic muscle cramp. And they call it clonus. And it's a rapid kind of fasciculation or vibration that happens. How many people get the eyelid twitch? Okay, that would be a clonic muscle cramp. All of a sudden your eyelid's going like a little twitch. How many of you, when you sit down after you've worked out or done something, and you kind of sit relaxed and you lift your heel up, but you don't have any weight on it, and your calf goes kind of crazy, okay? That's a clonic cramp. And again, they think that that's due to nerve irritation. Again, they're not 100% sure what causes it in a healthy individual. It is definitely sometimes a sign of a brain tumor. I know, that's what I'm saying. If they have other signs and symptoms, a very good friend of mine that passed away from brain cancer a couple of years ago, she's a pro tennis athlete, and she was having, they thought it was from her low back. She was having neurological signs and symptoms down her leg. And it was only when she said to my other friend, my physio says that she thinks I've got clonus in my Achilles. So whenever they put her Achilles on to stretch, she got this funny kind of fasciculation. And my friend said, you need to go get your head checked right now. Like, not like, meaning go get an MRI or a CAT scan done. And she had an inoperable brain tumor. She had one of those spider tumors that was in there. So, I mean, just not to freak you out, but that's what I mean, like nerve irritation. It was a central nervous problem, central nervous system problem in that case. So little eye twitches, those are like, I think, a little nerve irritation into the eye, and it causes it to go. So we're not quite sure where that comes from, but those are the two muscle types of cramps that you can see. So when it doesn't kind of fit a pattern, or it's happening repeatedly, then you have to start thinking, what's the other cause that could be going on here? Okay? So those are the types of muscle cramps that we can get. So it could be a central nervous system thing that's misfiring. Okay, strains. So how do we assess muscle strains? We use 4 parameters. Circumference. So taking a measurement around the muscle belly, a whole way around the muscle. It's a baseline evaluation to just get an idea of where they're starting from. You know, if you measure one person's right leg right around the middle of their thigh, it should be the same as on the other leg, on the left. If you do the right to the left. If somebody's had a significant injury and it's just happened, well, you would expect the injured leg to be swollen, so you would think the circumference would be bigger. Okay? If it's something that's been there for a long time and it's chronically been weakened, it might be smaller. There's some atrophy in there. Okay? Next, we use extensibility, which is putting the muscle on to stretch. And we have specific stretch techniques, particularly in the lower extremity, that have names, specific names, and we'll learn those when we get into the specific injuries. Okay, and so we would expect, we know that muscle length tension relationships should be a certain, everybody should be able to get like 90-degree straight leg raise. Some of you right now are going, yeah, like that's not going to happen, not in this life. All right, so that's what normal is expected, but as long as you're the same on both sides, we don't get too worried about it. Okay, and then we do contractibility, which is how much force can they produce. That's a manual muscle grading technique that we use. It should be performed mid-range of the muscle, length, and isometric. Okay. Mid-range is usually where we generate our most power, right? We're not as strong when we're out on a stretch, and we're not as strong when we're all crunched up. So that's why we're mid-range. Isometric, because we're trying to rule out joint problems. And then we give it a grade of 0 to 5. Okay, and I'm going to talk about those grades in just a couple slides and what they mean. And then the last thing we do is use our fingers to feel, palpate, right? And we go along and we feel for those lumps, bumps, gaps, the bunching. You can feel when a muscle's in tone, it feels more rigid, more tight. Some of you can go across your neck right now and find a nice trigger point in your neck. You go out and go, oh, little hot spot in there that's kind of hard. That's not supposed to be there. That's not normal. That's a trigger point. So you can go through and you can feel those and pick out where there might be a strain or an irritation happening. So a first degree strain, it's going to feel fuller. It's going to feel more tension. You run your fingers across it, you won't sink into it. It'll be a little bit harder. Second degree will be more sore plus pain. And then third degree, you might actually find that hole where the tear happened. You go on, all of a sudden, your fingers sink in. They're not supposed to sink in. So those are what we use: circumference, extensibility, contractibility, and palpation. Okay, so there's again that circumference. Just taking a baseline measurement really doesn't really tell us that much about the injury, just sort of the status, the overall status. We definitely do this post-op ACL reconstruction, or I always did. I would measure the good leg to the bad leg to see how much muscle they'd lost in their quad. And then that gives them a good objective measurement. Hey, you're at 25 centimeters, that's a skinny quad. But you'll get the idea. But they're only 20 on the other side, and they only got to build up 5 centimeters worth of muscle bulk. So it's a nice objective measurement for them. As I said, extensibility is putting it on stretch. We should all be able to get that top right-hand picture in that position. Believe it or not, 90 degrees hip flexion with a straight leg, that's normal length-tension relationship. Very few of us have normal length-tension relationships in our hamstring. Most of us might be lucky if we get to 70 degrees, 80 degrees, okay, with the leg straight, but that's normal. But again, if both legs are doing the same thing, then we're not too worried about it. Okay, as long as you're symmetrical, we're not going to get too, we might start to say, let's stretch that and try to increase that flexibility if we think we need to, but if we don't need to, then I'm a proponent of not fixing something if it's not broken. There was a tennis player, Grant Connell was his name. He was one of our big doubles players before Daniel Nestor came along. And this guy had the flexibility of an 80-year-old oak tree. You'd be like, okay, touch your toes. He'd be like, that's what I got, right? He couldn't do anything. But he could move around the tennis court just fine. Somebody decided he could make you a better tennis player if you're a little bit more flexible. So they started putting him on a really good stretching routine. He started to get injuries that he never had before. So they pulled off the stretching routine, the injuries went away. He wasn't having an issue with his lack of flexibility. So why would you go, so that's why I say don't go messing with something if it's not causing a problem at that time. That's my personal sort of bias and theory. Okay, so that's our extensibility, stretching. Okay, so contractibility. This is probably the biggest test that we use for muscle injury. It's the most telling, gives us the most information anyways. And again, you're always comparing to the non-injured side. It's always to a bilateral, it's always contained within the same person because everybody's going to be a little bit different. Okay, so a zero contraction, a zero response means there's no contraction. Somebody that's paralyzed has a zero contraction. They're unable to fire that muscle. Okay? 5 is normal and equal response. So, when we look at this chart, and this is pretty reproducible, and this is around the world, okay? So when I classify my wheelchair tennis players for upper extremity dysfunction, this is what we're using. And my colleagues are from Australia, the Netherlands, and Great Britain. And I was the newbie in 2010 when I went into this, and this is my trial by fire. They had to go out there, and they all sat there and watched me as I classified or assessed this athlete. And I went in there, and right away I was doing my muscle manual. I said, okay, grade 5, grade 4. And they knew exactly what I was talking about. Okay, so this is universal, reproducible, and is used around the world, these strength grading scales, okay? So 5, great, not a problem. 0, pretty obvious. Total paralysis, can't move it. What we're really looking for in sports medicine and returning to play and doing all that kind of stuff and figuring if it's a first, second, or third degree is this one, this 50%, the grade 3. Okay? The grade 3, you can lift against gravity 1 time. So you have enough force to lift that limb up against the resistance of gravity once. You try to do the second time, it's like, oh, I can't do it. Okay? So if somebody can do that once, second time they're sore, well then I might put them into a position where I get them mid-range and then I'll say, can you hold it there? And then you start to add your manual resistance to them. And then you gauge it. Are they holding more? Are they holding less? Is it just a pure grade 3? Or are we going into our 3+? You know what, I can actually give them a little bit of resistance and they can lift through that range. Or they're pretty good, but I can break them. I can hold them there for about 10 seconds and then all of a sudden they go, oh, and they let go. Okay, and there's usually pain. In this case, there'll be pain associated with this movement. So weakness with pain. So, and these are the actual numbers that we use. A 3, 4, 3+, 4-. Okay, just a little bit under that 5. That would be a first degree. So your first degree strain, you're going to expect them to have a 4+, 4 kind of strength grading. A grade 2, you're going to be a 3 to a 4 probably. A grade 3, you're probably going to be a 2 to a 3. You might be a 0 depending on if it's a muscle, it's the only muscle that does that movement. Usually in the body there's more than one muscle that does one movement. So if you've torn one hamstring, well you've got 3 others that can still do the movement. Right? You rupture your long head of your biceps, you still got your short head that can do its job. So that's the beauty of it. So there's a little bit of a carryover. If you rupture your Achilles, you still have your deep posterior calf muscles, so you can still plantar flex and still get a weak plantar flexion. Okay? Make sense? Yeah?
So can they go back to play with a 3+?
No. No, I would send somebody back to play with a 4+, maybe, and well protected, well strapped and padded, and yeah. But 3+, no. They're into second degree then? No way. No way. Not in my books anyways. Okay, so here's sort of showing you classic sort of glute med testing. Okay, one of the big ones that seems to be a target for a lot of people right now that have weakness in their glute med. Okay, resisted abduction, kind of a neutral position. Any other questions about strains? All right. Moving into dislocations. Dislocations, subluxations are a joint problem. And a dislocation is when we have a complete separation of the joint surfaces. So these are grade 3 injuries. We will be, if you've dislocated something, you are having capsule and ligamentous disruption occurring. Just depends on how bad it is. We tend to see more dislocations in the upper extremity. The shoulder is probably the most commonly dislocated joint. And fingers are right up there as well, especially in basketball and volleyball and football where we have to catch something, comes off the end of the finger and the fingers go ching. See ya. Okay, but you can dislocate your knee. You can dislocate your ankle or your hip. We just don't see that as often. Okay, and then subluxations are when the joint goes almost all the way out and then snaps back. So it's like a 3/4 dislocation. So you're looking at probably a second degree injury to the joint versus the third degree for the dislocation. So here's some nice dislocations for you. Okay, so that's an elbow that's going on the weightlifter. That's obviously a finger that's dislocated. Whole new meaning to pull my finger. That person wants that finger pulled really quickly. Right? That's how you would relocate that. You give it a good yank to pull the surfaces so it can come back in and get back into articulation. There's a dislocated baby finger there. That's a dislocated shoulder. Ball and socket joint. And the boxer could be having a dislocated face or jaw. Yeah?
What's the difference between a dislocation and a separation?
A separation only occurs at the acromioclavicular joint. Dislocations at the ball and socket joint. So a separation could be Yeah, that's, they just call the AC joints a separation as opposed to dislocation. Yeah. Okay, questions on that? Generally speaking, with dislocations, we do not reduce them. We tend to pack them in ice and stabilize them and send them to the hospital. They have to be x-rayed because you can obviously fracture on the way in or the way out, and you can also do nerve damage. So the general rule is that we try not to relocate. Now, that being said, a finger, as a volleyball player, I must have relocated I don't know how many different fingers in my life. I mean, I've got enough cricket fingers myself. Quick pull, tape it up, send them back out. Away you go. Volleyball players will do that. Shoulders, I've only ever had probably about 4 dislocations that I've seen live. 2 reduced spontaneously as I was putting them, icing them, getting the ice on, slinging them, and all of a sudden the shoulder goes, pops back in, like in Mel Weapon and Lethal Weapon, Mel Gibson. Gets back in there, and then you still pack them up. They still have to go to the hospital and get x-rayed because they could have fractured something on the way in or the way out. Okay? So we try not to relocate them unless it's absolutely their only hope. It's going to take, you're in the middle of nowhere, there's no ambulance or hospital around for hours, because when you're dislocated, it's really uncomfortable. And once it goes back in, it feels a lot better. Okay? So that's sort of what I go by. Next one, nerve injury. Again, this is something that you'll talk about more in 45-75, but you have to be aware of it in peripheries because we can damage the peripheral nerves. All right, so we've got cranial nerve injuries, so brain injury can cause problems. We can have damage to the spinal cord. Okay, that would be your paralysis, break your back, break your neck, become a quad or a paraplegic. And then we can have nerve root problems, so anywhere along, not right on the cord itself, but where the peripheral nerves start to come off on the roots, and then anywhere along that whole peripheral chain. So in the extremities course, we're looking at the plexus problem or the peripheral nerve problem is kind of where we're going to be more sort of thinking about it, and we have to be aware of it. And how do we damage those structures? They can be torn with the dislocation. As a joint dislocates, it can rupture through the nerve. A deep laceration, so a skater getting a skate cut or something can slice through a nerve. A fracture can slice through a nerve, and then you have some significant nerve damage along with the fracture as well. Also, if we have too much compression. Peripheral nerve is pretty funny. It's really happy if it's left alone, but as soon as you put compression on it, it gets cranky, or as soon as you traction it, it'll get cranky. And sometimes if you leave the compression on there for a long time, then that becomes the new norm, and then you take the compression off, and then it gets cranky. So peripheral nerve injuries are difficult to deal with sometimes. They're very long to heal, depending on how bad they are, and sometimes they don't heal at all. Okay? So again, just the nervous system. The nervous system is the only thing that is connected truly in one continuous line from the top of our head to our tip of our toes. Right? The gray matter of the brain, the meninges all come down and come off at the brain stem into the spinal cord, and that's the only structure in the body that is continuous. In one solid without interruption, right? All the muscles, they have ends and starts. Okay? Skin would be the other one that's continuous, but that's outside. Okay, this is inside. So one thing that you guys have to remember is the body and the brain is going to protect that nervous system no matter what. There's always going to be so if you've got any kind of threat to the nervous system, the brain's going to figure out a way to fix that or protect that. Except for when the brain itself gets injured, and then it's kind of funky. The research is huge what's going on now with brain injury and traumatic brain injury, and how that affects us. Okay? So for this perspective, this class, we're talking about the plexuses and the cords as they come off. So the brachial plexus in the upper extremity, right underneath the collarbone. We've got a lumbar and sacral plexus in the lower extremity that all come down and become the terminal branches. So in the upper, it's the radial, the median, and the ulnar nerve. In the lower, you've got the sciatic nerve, which splits into the tibial and the perineal, common perineal nerve. And then we've got the femoral nerve in the front and the obturator nerve, which goes into the adductors. And all of these can be damaged in their own right. Some of them a little bit more frequently. People hear about sciatica. You hear about that one all the time. Okay? And so we can damage anywhere along that route. And then it'll affect your muscle function below wherever the nerve is damaged. Okay, so we've got first, second, and third degree. We've got neuropraxia, which is a first degree, axial pneumesis is second degree, and neurotomesis is your third degree. Okay, so the neuropraxia, the burner, the stinger. These are the guys that will go back into play. How many people had a burner or a stinger? A few of you. Okay? How many people hit their funny bone and got the tingling that goes down the base finger? You gave yourself a neuropraxia. You're hitting the ulnar nerve. That's why you get the little, you find it right now. You can find your medial epicondyle, come up about a centimeter and tap right in the middle of it. If you tap in there, you'll probably hit your ulnar nerve and you'll get that little kind of a buzzy into your baby finger. Okay, that's your ulnar nerve. If you hit that hard enough and compress it and inflame it, you've got a neuropraxia. Okay, so this is very mild, usually full recovery, no major damage to the nerve. It's all good. Symptoms subside quickly. The axotomesis is the second degree, so this is where we now have some damage to the nerve itself. Okay, and the person may have some temporary paralysis, but they'll get close to 80% recovery, if not 100% recovery. And that 80% recovery, you'll usually have a full muscle return, full muscle function return. Okay, so injury can last from months to upward of a year. My cousin years ago, they thought he just had a herniated disc. He was having full-blown sciatica, was losing strength down the back of his leg. Yeah, bless you, yeah. Long story short, this is before MRIs were out there, so they x-rayed, they didn't see anything. And I guess the red flag here was finally his physio said, you know what, I'm a little concerned because we can't change it. We can't make it go, we're not making it better, we're not making it worse, it's constant, it's this constant, it's staying the same. He was losing his hamstring and losing strength. So they finally decided to do surgery on his back, and they found a tumor wrapped around his cord. Now, it was a benign tumor, but it was in there and it was compressing his centrals, and that was causing the problems. Okay, so as soon as they took the nerve off, that tumor was there for probably about, I don't know, at least a year before they took it out, right, because the symptoms were building gradually. And it took him about a year to get the strength back in that leg, but he got it back. Okay, so he was in sort of a second degree injury, and then they went in and they got it. So that's what I'm saying, like you put the pressure on and it takes a little bit of time. When you actually damage a peripheral nerve, it grows back, I think they say, 1 millimeter every 6 weeks. So depending on how much you damage, it can take a long time. That might not be the exact numbers, but it's something crazy like that. Like it's very slow to regenerate, if it regenerates at all. And that's peripheral nerve. Spinal cord regeneration, they're still working on. They don't even know if that happens, right? So grade 3 is your neurotomesis. This is where you have that nerve completely severed or completely crushed or compressed. Okay, so now we get 60% damage or more to the continuity of the nerve. And this person will have some permanent paralysis. Treated a young tennis player that fell off his bike. And he was riding and he landed and he did a burner, like a side flexion. And what he ended up doing was he separated his shoulder, but more importantly, he ripped C7, the nerve root, off. So he lost all of his, whatever C7 supply. So it was primarily his triceps was really affected. So we would lift his hand up over his head and we'd hang on up here, we'd say, hold it there. We'd lift it up there, hold it there. Like he had no tricep, it was gone on that side. This is a kid that was scholarship bound for tennis. How do you serve with no tricep? Well, he actually made his scholarship, he started doing sidearm, he compensated. It's pretty funky how the body will compensate when you don't have something. So there's other shoulder extensors, right? Your posterior deltoid. Okay, the only thing he was missing was elbow extension, so he's able to do two-handed backhand. I think he did a two-handed forehand, and then he did a sidearm serve or did something funky, but he was still playing tennis at a fairly high level. But he could no longer do this. It was gone. Okay? So complete third degree. So when I classify my wheelchair guys, I'm usually figuring out where they are on this scale, on their, how bad is their function, or how good is their function and their dysfunction with their injuries. So recovery prognosis is poor in this one. Not great. Yeah.
Is it painful or?
Oh, it was very sore to start with, but then the pain settles down pretty quickly with the nerve injury. I have another friend, he's a friend of my nephew's who was, I'll bring him up a couple times, he was trampolining, he was an elite skier, he was on the Ontario team. And he was out goofing around on a trampoline one day and he decided to throw one more jump and he, I don't know, flipped and twisted, he did something and he landed still rotating on the soft trampoline and he basically dislocated his knee, blew out the whole posterolateral corner, so he ripped the peroneal nerve. To this day, he still doesn't have dorsiflexion. And that was, that's gotta be 8 years ago now. They did a nerve graft on him. So he can ski no problem. When he gets the ski boot, he's locked in. He has to wear a splint the rest of his life to walk, otherwise he walks and drags his toes. He can't pull his dorsiflexors up. And they did a nerve graft on him, and it didn't take. But he also blew, his hamstrings were ripped off, his PCL, his LCL, his ACL, they were all torn as well. Yeah. So. Yeah. Little things that can happen, eh? Fun stuff. Any other questions about nerves? All right, fractures. Told you, I got lots of good stories from people that have wrecked themselves that are close to me. I don't know if I attract it or if I'm just more aware of it. My sister-in-law's looking like she's going in for surgery number 5 on her shoulders. Number 3 on one of them. Okay, so fractures. Obviously these are bone injuries, right? We fracture bones. A fracture is a complete or incomplete break. I get this all the time. Somebody says to me, I have a stress fracture, or I have a crack in my bone. Well, so then you've got a fracture. No, I don't. It's just a crack. A crack is a fracture. Okay? So incomplete or complete break. People think when I've got a fracture, you think, oh, it's snapped right in two. Well, no, just a simple crack partway through is still a fracture. Okay? We have our traumatic macrotrauma fractures. Those are what we're usually aware of. And then our overuse fracture is the stress fracture, the repetitive insult to the bone. It can't repair itself and regenerate, and eventually it starts to crack and fail. Statistically, men will see more fractures, but that's changing up to the age of 50 because females are now in more high-risk sports like playing rugby and playing hockey and things like that. So we are seeing a bit of a swing in this, and we're also recognizing that men also develop osteoporosis. But statistically, still up to the age of 50, you see more fractures in males than females. A little bit, it's coming down a little bit better. Okay. That's a javelin, where it's not supposed to be. Okay. Obviously, the knee is facing you, the foot is pointing to the sky. Something's wrong. And same thing here. This is my friend Jimmy Ramsey with the Rangers. Thigh, knee, foot's coming out to you. Okay, this foot should be going the other way. Okay, so when, yeah, like this guy, because this guy's going to go bark right now. He's on his way. He's like, oh, I can't look at that. Anyways, so it's usually pretty obvious when somebody has a significant fracture. It just doesn't look right. Something's wrong. But fractures can be deceiving, as I kind of mentioned the other day, when my friend had that fracture inside the knee joint, where it didn't show up on the x-ray until they actually did the bone scan. Okay? So, with the fractures, we have to know a little bit and understand a little bit about the bone. Okay? So, the epiphysis is the end of the bone, and that has that articular cartilage on it. That's where we get our articulation with the other bones too. That's where our joints are. The epiphysis is in the joint, usually, part of the joint. The diaphysis is the shaft of the bone. That's where the medullary cavity is. It has the red and yellow marrow. Okay, bless you. Oh, that's sneezing today. The red marrow forms platelets and red blood cells, white blood cells, the yellow marrow stores the fat. So when we fracture a bone, a major bone, we are seriously impeding function of other things in the body. We are no longer getting good blood cell formation because the red marrow is going to be all messed up. So if you fracture your tibia or your femur or something like that and it's mid-shaft, then it can impact your overall well-being because your red and white blood cells aren't going to be manufactured the same way on that side because everything's all leaking out into the wrong spot. Okay? The other thing that we have here again that you want to remember is we've got that thin periosteal lining on the shafts along the long bones. It does not go in and cover the epiphysis though. Periosteum does not come up onto that epiphysis. Now, at the top of this bone, Okay, this is a femur that you're looking at. You can see the ball of the femur, and then there's a line, right, just past the neck. That's the epiphyseal plate, or the growth plate. Epiphyseal plates are where we change length. That's how we grow. Okay, so that's an epiphyseal plate. Also called an epiphysis sometimes, just to get confusing. And then where it has epiphysis, and you see that little knobby thing that's sticking out there? Okay, we're looking at, I can't get it, but we're looking at that thing up there. Okay, yeah, my vertical's not so good anymore. That's an apophysis. Just to screw you up, they make them sound the same. That is an apophysis. That's your greater trochanter. If you hit the sides of your legs right now, come off your hips, and you hit this thing out here, you're on your greater trochanter. So your hip joint is a good 3 centimeters or 2.5 inches or whatever in from there is your hip joint. This is not your hip joint. That's your greater trochanter. Apophysis, change shape of a bone. Usually the site of a muscle attachment or ligament attachment. Don't necessarily change the length. Okay, so what comes into your greater trochanter? Your glutes. Med, max, min, tensor fascia lata. Lots of IT band comes off there, so it's a big attachment point. Okay. So the reason why we bring this up is we want you guys to know that we can have a fracture through the growth plate. And usually in somebody that hasn't completed their growing phase, so somebody under the age of 18, when they have damaged a joint, we have to be thinking and aware of the fact that maybe it's not a ligament problem or a joint problem, but maybe they have fractured their growth plate. Okay, and they call these fractures Salter-Harris fractures. And they can be significant because if you interrupt or disrupt a growth plate, you affect how that person grows and how they develop. And we'll talk about Salter-Harris fractures in a little more detail when we get into the specifics of the ankle, because Salter-Harris fractures are predominantly found in the ankle. And I literally just assessed a girl over Christmas that had a Salter-Harris fracture. She got her cast off on December 24th, so I saw her between Christmas and New Year's. And she obviously needed some therapy because she couldn't do some things. And I said, what type of fracture? And she said, I had a type 3. And so you guys will figure this out. I knew exactly what that meant. I knew exactly where the fracture went and what it did. And she was non-weight bearing 6 weeks in a cast, which is huge for a 16-year-old, 15-year-old. Okay? She's trying to get back into skiing for this year. I'm like, yeah, maybe by the end of February if it gets snow. Anyways. So fractures can occur to any of the bones. So we gotta know what type of bones we have in the body. Well, the easy ones, the long bones, radius, ulna, humerus, tibia, fibula, femur. Short bones, phalanges, metacarpals. Irregular bones, carpals, and the tarsals, kind of the irregular shaped bones. Flat bones, scapula, and some of the skull bones are kind of flat too. So we've got those, and then we've got sesamoid bones. The kneecap is a sesamoid bone. It's a bone that's embedded in a tendon. It's like a floating bone. All of these bones can obviously be fractured. We can fracture anywhere. None of them are sort of exempt from having a fracture happen if the right force and trauma is in the area. Okay, so how do we classify them? Simple or complex, partial, complete. We also go by the union of the bone. How does it look when the fracture happens? And then we have open and closed fractures, which are also called compound fractures or open fractures. So a simple fracture is usually one break, one direction, one line, one crack. Complex has usually got more than one crack in there. And then partial or complete again, so that's pretty straightforward. A stress fracture is a partial fracture versus a complete one all the way through. And then the closed fracture means it's all contained within the skin still. We haven't actually ruptured through the skin. And the open fracture, compound fracture is when the skin's ripped open to it as well, and we get lots of gross things happening there. So when we talk about the union of bone, it's the position of the fracture. Okay, so good union, they x-ray it, they cast it, good union, we're expecting great recovery. If we see a non-union, meaning that it's separated and it's not really joined up together, they're going to do something to make sure that we get it back in alignment. So a non-union, they may do surgery, they may plate that or screw it together. Okay? A malunion is the same thing. Totally, so non-union, they've got sort of separation. Malunion, that's really out of alignment. When they talk about setting a fracture, I've got to set that. That means they've got to snap it and get it back into place. Then they x-ray and they say, okay, now we've got good union, we're good to go. Sometimes these malunions are unstable once you get them back into place, so they have to pin or plate them. This is something that's done, you don't just start, as an athletic therapist, I don't make that decision, I just figure out if it's broken or not by looking at the shape of it, do my test, and then send it to the hospital, and then at the hospital they x-ray it, and then they figure out what they need to do with it. Okay, delayed union means that after a certain period of time, you're not getting any healing happening. And they don't really know what causes that. It could be poor nutrition, it could be bone density issues, it could be infection. They're not sure. Okay, so they decide if they want to do an open reduction internal fixation. That's the plating and the pinning, doing surgery on the fracture. So that's why not everybody has these lovely things that they can brag about. Okay, so that's a bimalleolar fracture of the ankle in the middle. So they've got two screws in the medial mal, and then they've plated the fibula to give that ankle, make that ankle joint stable again. That is a fractured femur, and it looks like they've had to replace the ball. So that could be almost like a part of a hip replacement procedure that you're looking at there. Okay, so those of you that have had surgery, there's a bunion being fixed. Sorry, that's gross. So that's a bunion or an arthritic change in a foot that they've had to do some serious work through a bunion. Yeah. Ugh. And just before we go, some more good ones just before you go have lunch. Right, so your compound fracture, right? Our basketball player, we've seen that one before. Fractured wrist. And then this guy just needs Harry Potter's polyjuice potion or whatever the heck it is to take that up. All right, let's leave it at that. We'll take up here on Wednesday.
As soon as I got up to my country, it fell over. Yeah? What is that?